Allah ya sa ta rike niki. Duka ka cire blue abin nan, ka cire blue abin nan. Ka ce da wai. Allah ya sauka. Allah ya sauka. Nace Allah ya sauka hajiya. Ni da kwame nace Allah ya sauka. Allah ya sauka. It's blood, but it's true.
Please come inside, though. Good afternoon. Please your mask. How are you? What's your complaint, madam?
This is going. And I took malaria drugs, not even want to.
Are you comfortable?
This is what is going to happen, or you should advise the child on taking.
Wait. Fever, cough. You say you don't have suffering.
I'm always cold. Cold.
Okay. How many days is this one now?
Started on Tuesday.
Tuesday, Wednesday, Thursday. Today is Thursday. Okay. So your body is hot right now. Is any other person coughing and running temperature around you?
My son, yesterday, morning, so he had headache. My husband put him on.
Is your mouth tasting sweet, Victor, or no? Yeah? You said what?
Yes, it's on that Tuesday. Don't sleep at night.
You are not vomiting, are you?
No.
Are you stooling?
Yes,
Demonstrate increment in that time. I think that will be very good. So if we can do that one, and then we also look at the indices from, you look at some of those other indicators that are high-level processes.
Okay. They've started already. My bag.
Abin da kike duka a sa miki wanda kike so.
Ina so na sha.
Kar ku zuba min da abin limon a falo fa an mun shara fa kar ku ya dafa.
There is a group program 5 to 8 for 3 days on cervical cancer and treatment. The last day. Okay. So anything came up from the GP? Not too much. The doctor should start.
Good evening, everybody.
Hey.
Good evening.
Good evening, ma'am.
Welcome, Joy. Welcome, Mrs.
Okay, I wasn't sure you were hearing me. I would like to thank you all for joining us for our final day.
Good evening, ma'am.
Yes. Day 3.
I was in the market when I said, I miss you.
Well done. Very Thank you very much. I would like to welcome you to the third and final day of our 3-day training on treatment of pre-malignant cervical lesions using Thermo-Ablation. We want to appreciate all who have been with us since day one and to say we are simply overwhelmed and amazed at the enthusiasm that's been shown. We've been having between 350 to 400 participants across Nigeria and possibly beyond, all wanting to learn more about how we can save our women from the scourge of cervical cancer. We want to especially thank our facilitators who have been awesome.
Are you
sharing
insulting us? Are you insulting us? Just be straight. You can.
We want to thank our facilitators who have been so generous with their time and their knowledge, sharing it so that all of us can work together. We may not all be able to provide the service, but practically all of us can create awareness, all of us can do advocacy, we can support these programs to ensure that women get the knowledge, women get screened, and women get treated. So without further ado, I would like to welcome our first speaker. He spoke yesterday, and when he talked about outpatient management of cervical cancer, pre-malignant lesions, and I actually got caught up because I was using 3 devices in Asaba, none of them were working. Today I'm using 4 devices and all of them are working. But I was able to listen to the recording, and I want to thank you so much, sir, for the details you gave to us. We are better informed, we are better taught, and I'm sure we can partner with you and your colleagues and everybody else to make sure that 90-70-90 becomes a reality for Nigeria. Please permit me to invite Professor Kayode Ajenifuja to give his presentation. You're welcome, sir.
Thank you, Madam President. It's my pleasure and honor to be invited to discuss this topic with our distinguished members. Today's topic, yesterday we discussed outpatient management of cervical pre-malignant lesions, but we left out one important, not deliberate because it was scheduled for today. Today we are discussing Thermo-Ablation. Yeah, these are the learning objectives. At the end of this lecture, the person should know indication for the use of ablative method, the criteria for the use of Thermo-Ablation, TA, contraindications for the TA, counseling of women before Thermo-Ablation, the expected treatment side effects, post-treatment counseling, and instructions. Now, nitrous, like we said yesterday when we were discussing cryotherapy, that I said we can either use nitrous oxide or carbon dioxide. When there are problems with the use of cryotherapy. The best gas to use for cryotherapy is nitrous oxide, but this is very scarce and very expensive. But it's better than carbon dioxide because it gives better freezing, more expensive, and very difficult to obtain. The other refrigerant is carbon dioxide, which is readily available but contains a lot of impurities. The impurities tends to block the cryo gun, that is diminishing the effect of freezing. So because of the blockage of the cryo gun, there is uneven freezing and ineffective freezing of pre-malignant lesions. Shortage gas, and again, the equipment is very bulky and very huge. Sometimes it's difficult to move them from one screening point to the other. And also, the gas in the cylinder may finish suddenly, and that gives a lot of disappointment. So this is an example of a nitrous oxide device. You can see how big that cylinder is. Well, there are smaller cylinders, but the problem with those ones is that the number of women treated are usually very small. So this is nitrous oxide, very big. Moving this from one place to the other is very bulky and cumbersome. So as a result of this, a lot of new improvement, new devices. Well, Thermo-Ablation is not so new. It has been around for some time. It's one called coagulation. But then they refined the usage of these devices, which is Thermo-Ablation. It has been introduced to overcome some of the challenges we face when we are using cryotherapy. Even before, apart from Thermo-Ablation, another method of freezing was also introduced. We call it gasless cryotherapy. That one uses alcohol. But the problem again is that also you have to wait for some minutes before for the machine to get charged before start using it. Now, Thermo-Ablation was introduced to overcome some of these challenges, and the principle of Thermo-Ablation is that it utilizes the effect of it to treat cervical pre-malignant lesions, unlike cryotherapy, which is cold. Both are ablative procedures, but unlike cryotherapy, this one uses thermal heat. Now, there are also indications, they have similar indications, Thermo-Ablation and cryotherapy. If we look at the WHO guidelines for the use of Thermo-Ablation, they are more or less equal. But then, people that have been on the field using these devices have actually modified. For example, look at the first criterion there, which is that the lesion must occupy less than 3/4 of the ectocervix. Actually, that applies strictly to cryotherapy. But with thermal ablation, you can actually coagulate, even if the lesion is very large, you can coagulate different points of the ectocervix. The second one is that the acetyl white must not extend into the cervical canal. Well, that is the general rule. But if you can see the upper limit of the acetyl whiteness, you can actually use thermal ablation. We have different types of devices. We have the endo-ectocervical. That one, there's a small extension of the probe into the cervical canal. You can actually use it, provided you can see the upper limit of the acetyl whiteness. There should be no genital tract infection, no PID, and no sign, very important, no sign of invasive lesions. Make sure the patient does not have any sign of invasive lesion. Thermal ablation is never used for even micro-invasive cervical cancer. It is strictly for pre-malignant lesion, the one that has not invaded the basement membrane of the cervix. Now, women should be concerned about the procedure, the expected side effects, which in most cases is usually watery vaginal discharge. Occasionally, there may be some bleeding, but it's very rare. So one should counsel the woman that after this treatment, you may experience some watery vaginal discharge, which will last usually about between 7 to 10 days, maximum 2 weeks. And during that period, there should be no vaginal sexual intercourse. So women may be very anxious. You can give them nurse-fed anti-inflammatory drugs, provided they don't have peptic oxide disease, because when the thermo-ablation devices are set to work, there's release of endogenous prostaglandins that can cause some cramp-like menstrual pain. Now, timing for unlike cryotherapy, that we use an average of about 30 minutes. That is 3 minutes to freeze, 5 minutes to thaw, another 3 minutes to refreeze. Thermo-ablation lasts less than a minute, and the timing is essential. And during that period, the provider must maintain eye contact with the cervix at all times. We don't want the heated probe to touch the vaginal wall, because if it does, the woman will feel pain. And when she feels pain and she jumps off from the couch, the device just touches all the vaginal walls, causing more damages. So it's important that the provider must maintain eye contact with the cervix at all times during the procedure. And the heated probe must be in close contact with the cervix, and accurate timing is important. In the old devices, someone has to time, or you time yourself. But the new device being introduced now, it comes with a timer that will beep and tell you your treatment period is over. And the heated probe should avoid contact with the vaginal wall that probe during the course of the treatment. This is the Thermo-Ablation device. This is the first one. This is the old one. This one is by WISAP. There are 4 probes there. 2 on the left, 2 on the right. You can see the one on the right has a small nipple at the top of the probe. That one can be used to treat lesions that extend slightly into the cervical canal. I don't know if we'll have time to watch a small video of how to use the Dharma. I'm really excited to show you. Can you hear me?
Yes, we can hear you.
Yes, we
Can you hear the speaker, the video? Is it clear?
Clear.
Start again, sir. We can't hear.
Okay, don't worry, just watch. It's self-explanatory.
Or if you can increase the volume, sir.
She's going to connect the machine. She's connecting the machine to the cable to the machine and to the probe. And the machine is connected to the wall socket. She's putting on the gloves. You don't actually need surgical gloves for this. Latest gloves will do. Then that's the knob where you can increase the temperature to about 100 degrees centigrade. That probe is only the tip of that probe that is very hot. It reaches temperature of about 100 degrees centigrade. Unlike lip, you don't need an insulated speculum. Ordinary speculum, but please try not to use a plastic speculum because if the heat gets in contact with the plastic speculum, it will melt. So she's putting the male condom to prevent contact with the vaginal walls. If you don't have a male condom, you can use the latest glove. Just cut the tip of the condom. For some multiparous women, they may have lax vaginal walls that tend to prolapse into the vaginal canal. So she uses that male condom to keep vaginal walls apart. The whole of that probe is very cool, except that black, the tip, that is where the heat is transferred. So she's gently introducing it through the vagina onto the cervix. And treatment lasts less than 45 seconds, unlike the cryotherapy. As soon as you are done, gently remove the probe and switch off the machine. So there are new devices being introduced now. This one has a sheet. This is a new WISAP, and it has a power bank. So you don't need to connect it to a wall socket or to power it. So you can actually use a power bank for it. It has a timer that warns you that instead of somebody timing for you, it has a timer. If you look at the probe very well, you can see the sheets. Can you hear me?
Yes.
Yes, sir.
Yeah, this probe has a sheet that protects the vaginal wall. That's the power bank there. So you can take it to any remote part of the country and start treating women. There's still another method by Liger. I think we'll skip this one and move on. So this is the cervix before the thermal ablation is applied. And this is what the cervix looks like after you've done your treatment. Those are the new devices being introduced now. This one also has a sheet. You can see the probe on top and there's a sheet underneath it. That protects the vaginal wall. Now, what are the side effects of Thermo-Ablation? Like any ablative method is watery vaginal discharge. There may be some menstrual-like cramps. Bleeding is very rare. And after the treatment, we need to give post-treatment instructions to the women that they should report back to the treatment center if the discharge becomes bloody or foul smelling, or there's excessive bleeding, or she has severe low abdominal pain. They should be advised to abstain from vaginal sexual intercourse for 2 to 3 weeks post-ablation. And if it is impossible to abstain, clients should use the male condom. The post-treatment follow-up is critical, particularly for women living with HIV/AIDS or women for non-HIV status in areas of high endemic HIV infection. Now, these are the steps before Thermo-Ablation is used. We need to counsel the women on the procedure and possible side effects. We ask her to lie down on the examination couch. We part the speculum to visualize the cervix. We must make sure that the lesion does not extend into the vaginal fornix or to the vaginal wall. If there is extension into the canal, provided we can see the upper limit of that acetate whiteness, you can use the thermal probe with the vaginal, with the one that covers the endocervical probe. You can use that one. Now, if all these, the initial 4 criteria, if any of them is positive, the woman should be referred for LEAP. The instrument should be assembled and set the timer. The heated probe is applied on the ectocervix for 45 seconds. Remove the probe and observe for 15 minutes, discharge home with instructions. Now she should report back if she has foul smelling discharge, blood-stained discharge, or abdominal vaginal bleeding. It is very important to give the instructions to the women. Now, this is the treatment algorithm for the use of Thermo-Ablation. If a woman is referred to your center for Thermo-Ablation, please confirm that the woman actually screened positive, in this case with VIE. If she screened negative for VIE, then ask her to return 3 in 5 years if she's HIV negative, or 3 years if she's HIV positive. Now, if you suspect that the woman has an invasive lesion, cancer, refer immediately to facility that can diagnose and manage cervical cancer. Now, for all positive cases, if the lesions less than 75% does not extend to the vaginal wall, you can counsel and treat her. If the patient refuses or wishes to defer treatment, then you need to counsel her, take her phone number, if possible, home visits. Example of a service. This is, I don't know if I may, a short quiz from members. This woman, is she eligible for treatment with Thermo-Ablation? Any volunteer?
No, because it extends into the endocervical canal.
Okay, that's correct. Any dissenting voice? No need. How about this patient? This one? Is she eligible for treatment?
She's eligible. She's eligible.
How about this patient? Is she eligible for treatment with Thermo-Ablation?
Yes.
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 No, she is not.
Yes.
Why? Who said no?
No, she's not, because there appears to be extension to the vagina.
Vaginal wall.
No, there is no extension. Why do you see there is no extension to vaginal wall here? Look at the image carefully.
There's no extension into the vaginal
There is no
wall.
extension to
She's
vaginal
eligible,
wall.
sir.
Yes. Now, even if your probe does not cover the acetate white lesions, you can apply sequentially onto the acetate white areas of the cervix. How about this patient? Is she eligible or not?
Yes.
She's eligible. She's eligible.
She's eligible.
Now look at this
She's
service.
eligible.
Sometimes when you do
She's
VIA,
eligible.
you may see what you call strawberry cervix. You can see the way the cervix looks like. That is an trichomonas vaginalis infection. So, ladies and gentlemen, treatment of cervical pre-malignant lesions must be appropriate and adequate for effective cervical cancer prevention. Over-treatment or under-treatment must be avoided at all costs. So once again, I thank you for listening.
Thank you,
Thank you, Prof.
Thank you very much, sir.
Yeah,
Thank
I don't
you
know
very
if
much,
there's
Prof.
any question.
Thank you so
I can
much, Prof.
quickly take the
Thank
question.
you so
Thank you,
much, Prof.
Prof.
Because I have another
Prof.
meeting in the next 20 minutes. I don't know if there's any question. I can quickly trash it out. I have another meeting in the next 20 minutes.
We can take questions.
I
Prof.
have a question, please. I have a question.
I have a question.
I have a question.
Hello.
Yes, ma'am. I'm listening.
Yes.
Can you louder, please?
When you are done with the thermal ablation equipment, you finish with the patient. How is
Hello,
it
ma'am.
kept? How do you put it away?
Well, let me show you a picture of that cervix. Of that picture, rather, device. Now, have a look at this. You can clean it thoroughly. Once you clean it, if you are using this old machine, there are areas beside the machine where those things can be kept. Now, can you see my cursor?
Yes.
This is the one with the small nipple there that can be used for slight extension into the endocervical canal where you can visualize the upper limit of that acid whiteness. Now, this is flat, this is another flat one that you can use. You apply this on the cervix or the ecto cervix, and if you have very large lesions that this probe does not cover, you can actually divide them into different segments and you apply your treatment. You don't have to cover all the acid white areas at once. Does that answer your question, please?
It does. I actually wanted to find out if you are handling an HIV patient.
Yes.
And you need to move on to a patient who is not HIV positive. Yes. How do you go about it? I know there are different probes, but in cleaning, what do you do?
You can use glyceraldehyde to clean the probe.
Okay.
And again, the effect of heat itself will destroy because this temperature goes as far as 100 degrees centigrade.
All right. Okay. Okay.
So the effect of heat, and you can use glyceraldehyde to clean it.
Okay, sir. Okay. Thank you, sir.
You're welcome. 3 participants are raising their hands.
Thank you, sir.
Yeah.
Yes, thank you, sir. I had wanted to ask this question yesterday, but I couldn't for network issues. I really appreciate you for all that you have done and every other facilitator. My name is Dr. Esson from Osun State. I want to ask, sir, that in practicing, these things, we are going to be having physical trainings. Can we use some other things to start before maybe meat?
Sure. You can
something
use a piece of beef. Yeah, that's possible.
Practice.
Yeah, you can use that
before using all this on human flesh.
Exactly. Yeah, you are very correct. Even for my resident doctors, the beginners, I ask them to get a piece of beef and they practice. Even lip, you can practice lip Thermo-Ablation on a piece of beef. It's very possible.
Okay, thank you, sir. Then the other question is, well, I know that as public health physicians and family medicine and any other kind of person who is not a gynecologist can do this.
Oh, sure.
But do we need any? Okay, nobody needs any particular license again besides being a doctor. So nobody comes back tomorrow to sue anyone that you are not a gynecologist. You are doing this.
No.
Yeah.
Any doctor, any health worker, even nurses can do it.
Okay. Thank you so much, sir.
You're welcome.
Thank you very much, Prof.
Yes, ma'am.
Prof, please, I wanted to know if paraventure does an advertent bond to adjacent structures like the vagina, how could that be managed for the woman? And when do you continue the treatment process you had already started, assuming there was that
Madam,
problem?
that probe,
Yes.
the temperature at the tip of the probe is about 100 degrees centigrade. So we need to counsel the woman to be still and not to move during the procedure. We should have warned her that she will have menstrual-like cramps during the procedure, so that when the cramp starts, she will not jump up. That probe being in contact with the cervix, the woman for the next 45 seconds or thereabout during the duration of the treatment, she is not expected to move. Should the woman move because she has not been pre-warned, what is likely to cause multiple burns on the vaginal wall. At that point, one should stop the treatment and quickly turn off the machine. It's very important, and observe that woman before discharge home. Because the vagina is a canal. The moment the woman jumps up, the thing touches almost everywhere on the vagina walls. And that will cause multiple burns. We should try to avoid this, because if we are doing, mind you, like I said earlier on, women with cervical pre-malignant lesions don't have symptoms. No vaginal discharge, no bleeding, nothing. Now, if this woman should come and she get burns on her vagina, and she gets out here in the public and tell people that don't go there, the last time she was there, they caused her injuries, other women will not come back. Remember, bad news travel faster than good news.
Exactly. Okay. Thank you very much, sir.
You're welcome.
Thank you, sir, for your presentation. Please, is there no need for anesthesia during this procedure?
No need for anesthesia. No need. The vagina, the cervix has little or no pain receptors, but has stretch receptors. That's why you can take a biopsy, a punch out of the cervix without that woman feeling any pain. But the moment you try to dilate the cervix, she feels pain, because cervix is innervated with stretch receptors. That's why women feel pain during cervical dilatation when they're in labor. But then you may give non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs to counter the effect of the release of endogenous prostaglandins. So there's no need for anesthesia. The procedure lasts for 45 seconds. The actual therapy itself lasts for 45 seconds or less in some devices.
Thank you, sir.
You're welcome. Any further question, please?
Yes, sir. Good evening, sir.
Good evening, madam.
Thank you very much, sir, for the presentation, sir.
You're welcome.
Please, I want to ask that after the procedure, sir, do we need to, the patient needs to come back for follow-up, maybe for a follow-up pap smear or for another VIA, and at what time they need to come back?
You might need to see her 6 to 9 months after the procedure. We assume that she has been properly taken care of. But you may ask her 6 to 9 months,
by the time we are
healing might have completed by then just examine the service to see.
Okay, we don't need to do another VIA at that point in time.
No, you don't need to do another VIA at that point in time.
Okay, sir. Thank you very much.
Welcome.
Okay. Thank you, Prof, for that educative lecture. Please, my question is, how long after LEAP or thermal ablation should the woman abstain from sex
Yeah, as long as she has the watery discharge, she should abstain from sex. That is why pre-treatment
No,
counseling.
what I mean is, I think my question is not clear. What I mean is, how long after should she be allowed to have sex?
Well,
how long after the ablation should she be permitted to have sex?
Yeah, some women will have vaginal discharge, watery discharge after the procedure. As long as that discharge is there, she should abstain. Even if she does not have vaginal discharge, because the place is still raw, right? Maybe 2 to 3 weeks after the procedure before she commits sexual intercourse.
Okay. Okay. Thank you very much.
Hello, Prof. Thank you, Prof, for that wonderful lecture. My question is about the fact that during yesterday's lecture, I noticed that it was said that for people with HIV, that the time they have to come for a repeat test, if the test is negative, is three years. For the normal patients, 5 years. So, but I've always known that before now, that for normal patients it used to be 3 years, but for HIV patients 1 year. So that's where I got confused. I don't know if it's a new
No, it's a
guideline.
WHO recommendation, 3 years.
Is the latest guideline now?
Well, I've not said, I think it's WHO recommendation. I'm not sure if it's but it's WHO recommendation that 3 years for HIV positive patients, and for non-HIV 5 years. Ideally speaking, at this stage, we shouldn't be doing VIA, honestly, because there are cheaper methods now to screen for cervical cancer. But then, since in the absence of nothing, we'll continue doing our VIA.
Because I was looking at the duration as being too long.
No, it's not
5
long.
years
Why?
and 3 years.
But you've treated that. No, it's not long. Really, people have not really determined the interval to screen with VIA, sincerely speaking. In fact, very soon now, what is being advocated for almost all countries now is HPV, private HPV screening. That one gives very high negative predictive value that once you are negative, you are negative. You are not likely to have another infection for a very long time to come. But with VIA, 3 years for after treatment for HIV positive patients and non-HIV, 5 years. That's the recommendation.
Thank you, Prof.
Dr. Rekia, I can see your hands up.
Yes, sir. Good evening, everyone. Thank you very much. I missed some of your presentation. It's a bit dark here. I just wanted to add, to follow up with his question here, that I think determining the interval of screening depends on the country. The country decides. Unfortunately, a lot of times we copy the American system when we are not America, but it depends on the country. For example, like in South Africa, based on their economy, a woman should be screened. If she's HIV negative, she starts screening as soon as she's diagnosed HIV. And then every 3 years after that. And if she's HIV,
screening.
They commence screening at that, and they commence screening based on the national guideline, commence screening for HIV negative from the age of 30. So in South Africa, it's from the age of 30, and it is done every 10 years. So for that, they calculated, but they are doing cytology-based screening all over the country, and that is what is recommended. That is what the government is doing. But the other thing is that it is done like there, you see, I'm sorry to make this comparison, but screening is not a tertiary institution stuff. It is done at the primary care level in the community. So it is done by nurses, and it is cytology-based screening. Any woman that comes to the tertiary clinic for a pap smear, she has to pay through her nose for that. So at the community level, everybody gets pap smear. And then if they are free, yes, it's free. You don't pay, you just walk in, whether you are a national or not, you just walk in and have your pap smear. And you get the result in 6 weeks' time. If you don't come, the sister will look for you. If you have a high seal pap, then she refers you to the secondary or the tertiary facility for colposcopy. Now, because there's a lot of pressure on the colposcopy services, now they are beginning to decentralize it such that health workers, medical officers now at the primary care levels are beginning to do colposcopies and lips. And there's a plan to also expand it to the nurses. So I think the interval depends on where you are. So in South Africa, it's every 10 years for HIV negative. So a woman will get 3 pap smears in her lifetime.
Thank you, Dr. Kia.
Yes, sir. Yes, sir.
The interval in South Africa was based on research done locally.
Yes, sir. Yes, sir. It was based on research.
Unlike us here that we just copy what is being. When you see people writing guidelines here, guidelines actually should be based on hardcore evidences, research, evidence-based. But since we don't, very few research is going on here, so we tend to copy. I agree with you perfectly. Also, they don't do VIA anyway. It's cytology, and our land is moving to primary HPV screening.
Yes, they are. They are not doing VIA at all. In fact, it is totally rejected. Let me put it that way.
No, it's not what doing. I agree. It's not what doing anyway.
It's totally rejected. So what is done is cytology-based screening, and most of the provinces or the states have moved on to liquid-based cytology in preparation to moving to HPV testing as a form of screening. But like where I am in the Western Cape, they are still doing conventional cytology. Yeah, because they want to move straight to HPV testing instead of going through liquid-based cytology before going to the HPV testing. And also, I think I'm glad there are policymakers here, because if you look at the HPV vaccination, I'm sorry to bring this up, in South Africa, because they are not Gavi eligible, because they are a lower middle income country, the government is paying for HPV vaccination for all the girls in grade 4 in public schools. So now there's a call to please expand it to the private schools. And since 2014, millions of girls have been fully vaccinated, 2 doses of Cervarix. So I think it's something, we are actually richer than that country, honestly. And I think we can actually put our heads together. MWAN should champion this and move it up.
Thank you very much. Yeah, any further question?
Yeah. Yes, sir. Good evening, Prof. Thank you very much for the lecture. I don't know whether I should ask this question, but I'm just prompted to ask. You said that the machine should be calibrated to 100 degrees Celsius. Is there a rationale? Excuse me, is there a rationale behind it? Because if I say I want to calibrate it to 90, does it mean that it will mean that it is suboptimal? Or if I make it to 100, does it mean it will cause burns? Or have you done any, just as Dr. Mrs. Reke has mentioned, what the research done in South Africa? Can it, a similar research be done here to know to what, or the 100 is adequate enough to treat or cure the patient?
Yes, that's what the manufacturer recommended, 100 degrees centigrade. Some manufacturer recommend 100 degrees centigrade, some recommend 30 seconds, some recommend 45 seconds, depending on the manufacturer. But 100 degrees is standard. The initial one was actually 120 degrees centigrade, the original WISAP, but they reduced it to 100 degrees instead of 120 to 100 degrees.
Thank you, sir.
Yeah. Any further question? Your network is. Oh, we can't hear you.
Hello, ma.
Yeah.
Hello, Prof.
Yeah, good afternoon.
To the chat so that hello, are you hearing me?
Yeah.
I am asking if they can send their questions in it. You had another meeting to go.
Okay.
Hello, Prof.
Yes, ma'am.
I'm asking because of teaching.
Time.
Hello.
Hello. I think I have some.
Prof, are you hearing me?
I can hear you.
Okay, you have. Okay, so let's share will be the last person.
But she's not very audible. I think she has a network issue. Can somebody quickly ask a question? Start.
No.
Hello.
Hello, Prof. I muted her.
Yeah.
I muted her.
Okay.
Hello, Prof.
Yes, she's
yes.
Now.
Thank you, sir, for the wonderful presentation. Really
welcome,
appreciate it, sir. Sir, I don't know if I'm just thinking about it.
Thinking about what?
The network has gone. That's why she should put that for them to put their voice. So, probably for staying back and questions. We will continue with you and see you to more info to do on the way forward. I want to really thank you. 2 days you have given us this. They have been very easy. Thank you, sir.
Welcome, ma'am. Yes, ma'am. Bye.
So we would now like to call Dr. Michael. Dr. Michael is going to give us, Dr. Michael Ezianoche is going to give us the next presentation on referral and follow-up. Dr. Michael, can you share your slide, please? Thank you.
Good evening, President and participants. I don't know if you can see my slide.
We can see your slide very well.
Okay, thank you. So I will be looking at referral and follow-up plans for patients who come for screening with cervical cancer. I have put up my video so that it doesn't disturb my internet bandwidth and signals. So I hope you can permit me. Our outline will try to look at what is referral and how it links to a referral system in healthcare. And then try to look at some of the criteria for patients to be referred through the health system in screening and management of pre-malignant lesions of the cervix using the See and Treat VI program that we have been discussing in this workshop. And then how you follow these women up. And I'll just share some personal thoughts on what I think can be next steps for us to consider and ponder about before we conclude. So in terms of the healthcare system, the organization of the persons and institutions and other resources that deliver healthcare refers to a healthcare system. They are all linked up together. The fundamental purpose of healthcare is to enhance quality of life by enhancing health. When providing healthcare to the population, it is important that it is networked and the different facilities and levels of care are linked. So there's a continuity of care. I say this especially with reference to cervical cancer screening, where we have a lot of opportunistic screening outreach programs. The goal of screening is to reduce the prevalence of cervical cancer in the population that we are working with, and thereby reducing morbidity and mortality. So it is best for impact when it is provided within a system that is linked together to offer increasing complexity of care to patients. So there should be some sort of a need for a communication between these. Referral is a process in which a health worker at a level of the healthcare system who has insufficient resources or skill to manage a client with a condition seeks the assistance of a higher level of care or a better resource facility. In terms of cervical cancer screening, referral and linkages is necessary so that we can give high quality service. Now we're teaching how to do VIA, how to do outpatient treatment, cryotherapy, thermal ablation. It is also good to put into perspective a need for linkage between the lower levels of care and higher levels of care, and identifying patients that need to be pushed up to the next level of care for quality assurance purposes. Quality assurance is to ensure that our primary goal of entering into the realm of screening is achieved as part of secondary control of cervical cancer. So we refer patients to ensure that they receive appropriate and cost-effective management that will lead to the desired goal of managing the pre-malignant lesion. And also, it helps to create a linkage and a network where health care professionals can move patients up and down. So if a primary healthcare center refers the patient to a secondary or tertiary level, it creates that semblance that when you send the patient back into the community to the primary healthcare center, that someone there is going to continue care and can communicate with you if problems and set up. So it creates that confidence in the system among healthcare professionals, and also gives the patient or the client the quality of service that they require. Now, for cervical cancer screening, I have adapted this from the National Policy Document for Nigeria for cervical cancer control. It just helps to put us into perspective what we've been discussing and how these services should be offered. It looks at it in terms of a three-tier level: primary healthcare, secondary healthcare, and tertiary healthcare. If you see the services available, it is graded with increasing complexity and difficulty levels. It envisages the goal in the Nigerian program is to have HPV testing as the mainstay. But we do know that HPV testing is a bit more expensive and not so readily available or accessible, and funding mechanisms to deploy it have not been discussed. So it also allows for the use of visual inspection with acetic acid or losartan. It envisages that at the primary level of care, we can offer VIA, ablative treatment. Thermal ablation is the focus now, and then cryotherapy was also available previously using the see and treat approach. We know the advantages of that approach. You don't need to have multiple visits. It is also feasible to treat. If you do it properly, you can identify those that require treatment, and so it is resource efficient. Now, at the second level of care, typified by general hospitals or big hospitals that have the requisite competence in terms of human resources and equipment, we can also offer what is available at the primary level of care, VIA and ablative therapy. But in addition, the Nigerian policy document looks at excisional therapies can be available at the secondary level of care, which requires more skill, maybe associated with increased morbidities, and also requires additional resources. So colposcopy and biopsy of lesions if indicated. So it looks at the access to ability to do histology and get reports. While at the apex of this referral system are the tertiary healthcare facilities. So these are centers that can do screening, offer comprehensive care for cervical cancer prevention, from screening, ablative treatment, excisional treatment, biopsy, surgical, proper management of invasive cervical cancer, radical hysterectomy, radiation therapy, chemotherapy. So if we understand this, we can see that at the tertiary level of healthcare, not every tertiary health facility may have the competence to offer it, but centers that do can be looked at to offer tertiary care within a contiguous geopolitical location in Nigeria. So understanding this system, referral system for cervical cancer screening as recommended by the government, what are the criteria if you go to, or if you are a provider at the primary level of healthcare, why we want to refer a patient? I'll just recap some of what we've had in the past few sessions. So a patient comes into your center and you screen, you need to find out who is eligible and who is not eligible for this service. If the patient is not fit or eligible to be managed at a primary level of healthcare, then we should refer. And these patients may include persons that you see an obvious lesion on the cervix, or you suspect may have invasive cervical cancer. Then if you do your VIA and the acetyl-white reaction you get is quite extensive, like the one that is displayed, and then covers more than 75% of the area of interest. So you can see it's just a small area here that is free. The rest of the cervix is acetyl-white, and it may be difficult to properly treat this lesion with ablative treatment. And then so it may be a high-grade lesion, so you require further testing and maybe excisional therapy. And then if you have lesions that are extended into the endocervical canal, like Dr. Timothy just said, they may not be feasible for ablative treatment, and so you need to send for excisional therapy, because it's important to see the entirety of the transmission zone so that you can treat confidently. And then if the structure of the cervix is such that you may not be able to properly treat with your Thermo-Ablator, then based on the size of the nipples you have, then you should also refer that patient. And so we can see that it's not everybody that comes into our healthcare facility and we screen positive that we should just offer Thermo-Ablation or cryotherapy. We need to remember these parameters so that we offer appropriate service in a qualitative manner. We don't undertreat lesions that are quite high grade or offering ablative treatment for lesions that are invasive cervical cancer. So I know many of us here may not be gynecologists, and then we are eligible to offer screening and treatment, but it's good to remember this criteria so we are offering the right service to the right client. And those that are not fit for the service we're offering, we should have where we can refer them to and counsel them so they can get proper care. Now, at the secondary level of care, besides screening, they can offer ablative treatment and excisional treatment. So some patients may not be fit for treatment at the secondary level of care. If you see a lesion that you think also is suspicious for invasive cervical cancer, like the image I have displayed, then excisional therapy likely it's not feasible, it's a strong treatment. And if you decide to go ahead, you may have torrential bleeding, morbidities, or even possible mortality. And then lesions that the lip device you have, or you think they are not feasible for lip excision, especially when they are quite deep into the endocervical canal, then you may need to send to a tertiary center. I think the main point here is to understand that whatever service we are offering should not be a standalone service. We should have at the back of our mind higher level healthcare facilities that should serve as a referral point where we cannot even interpret the results, or it's not clear, especially as we are beginning to refer to and can communicate to those centers so there will be good feedback and we can improve when we see the next patient. So at the tertiary level of care, this should be the apex. They should be able to offer screening, ablative excisional treatment, and radical hysterectomy, radiotherapy, and chemotherapy. So yes, most patients will be properly managed at this center. But occasionally, sometimes you may not have radiation treatment capacity in your center, but you can offer surgical treatment, hysterectomy, and chemotherapy. So you will find out that even teaching hospitals need to form linkages and network where patients can move vertical and horizontally across teaching hospitals. You can prep them up with chemotherapy, and they go and get their radiotherapy at the nearby center, and they can come back to you to continue follow-up and other treatment. So it's quite clear that we should envisage that we are not going to be offering service as isolated islands in silos, but the ultimate, it should be offering screening and treatment in an organized platform that can achieve quickly our goal of reducing cervical cancer prevalence and also morbidity and mortality, and offering patients the right quality of care. So follow up. After the patient has been screened and treated, we need to put in place a lot of opportunistic screening programs that we do. We do outreach, we screen, we treat, and we leave the communities. But ideally, that should not be, is not good enough. We should try to have a system or a mechanism in place to track women who have interfaced with our service and follow them up. When I go to the next slide, you see that there are time sequences where we need to carry out further testing for these women. In busy facilities, it may be advisable to designate a health personnel, not necessarily a doctor or a nurse, but a lower level of an allied health worker who can help, it's public health, who can help in tracking these women and following them up, or even send reminders when they should come for their repeat visits. I know in the UK, despite the successes they had in using pap smears for cervical cancer screening and treatment, when they started the call and record system where they got in touch with those who missed their follow-up visits, they were even found able to reduce the prevalence of cervical cancer in their populations. You should actually document your referrals and have a referral directory and a facility summary form for patients who are going out and when they are back to you. It facilitates the continuum of care for the patients within the healthcare system. So, yes, I know we were having discussions previously on different screening intervals. I think the national program and the WHO have recommendations with the 2020 guidelines. And I'll just share some of the lifted from those guidelines. So if you screen a woman in a C&G program, and she tests negative on VIA or for repeat screening should be every 3 to 5 years, as Professor Jennifer just said. Now, so these are people who are of unknown HIV status, and we assume that the burden of HIV in that community is not high. If you are using HPV testing, which is the gold standard now, and probably the direction for the future, screening should be done a minimum of interval of 5 years. So it's based on resources and based on national evidence and competence. So that's why we can see South Africa stretching theirs to 10 years, and they plan to offer you 3 tests between 30 and 50 years. So yes, the guideline for those who are negative is they can repeat it in 3 to 5 years. If you don't have a database of patients that we have treated, or you do opportunistic outreach, you find out that you go back the next year, the same patients come back, they are screened and maybe retreated again. And so you are expending resources on patients who may not need it. But if you know those who have been screened within in less than 3 years, you be confident tell them based on our knowledge of the life cycle of the human papillomavirus that your risk of developing invasive cancer within that 3-year window is quite low. So let's focus on those who have not benefited from the program. For positive tests, now in women who test positive for VIA or cytology and are treated either with ablative treatment or loop excision or cryotherapy, their first screening after, because they've tested positive, you want to be sure that your treatment was effective. It may not be effective all the time. You want to be sure that your treatment is effective. Then you should screen them again after 1 year. And if after that 1 year they are negative, then they go back to routine screening where you see them every 3 to 5 years. Now, for those who test positive on an HPV test and also are treated, then they should also be seen been treated. The goal is to ensure that we see them within 1 year to try to confirm that our treatment was successful. And if it wasn't, to early and to try to additional treatment as necessary. HIV positive patients are a special subpopulation because for HIV positive persons, their ability to control or clear HIV infection is impaired, and so you may have more rapid progression from infection onto the development of invasive cervical cancer. So we're a bit more active in managing them. If a HIV positive patient, or if you are screening in an area where the burden of HIV is high, then if it is negative, the screening interval for repeat screening should be within 3 years. So you could choose 1 year, you could choose 2 years, but it should be within 3 years. Unlike for HIV negative persons, they tell you 3 to 5 years, it should be within 3 years. So some persons may choose 1 year for HIV positive patients, some persons may choose 2 years or 3 years, but your local circumstances or context is important in deciding what you think should be the ideal time for that. Then those HIV positive who tested positive and have received treatment, we will follow them up at 1 year. You don't have the liberty now to choose within 3 years. Follow-up should be, like even HIV negative women, should be at 1 year. Now, I'll just take us down to say, after we've had this wonderful seminar in the last 3 days, we've looked at introduction to cervical cancer epidemiology. We have looked at screening methods that are available and talked about even outpatient management for cervical cancer. What should be the next step? Do we go back, sort of reflecting now, do we go back and continue standalone opportunistic screening programs? Or do we look forward to a way where we can have an organized screening programs? It doesn't necessarily need to be with the government. So we need to decide opportunistic screening or organized screening. What should be our decision? Organized screening based on evidence has the potential to offer the greatest impact in reducing cervical cancer burden, where you track the patients as they move within the system, and you can remind them to come back for screening at the appropriate time. When the different levels of healthcare facilities have a platform or framework for communicating with each other, and if you are sending the patient from the teaching hospital to the primary care center, there are advisories on how you should continue for that management or manage complications, or when to send back to the teaching hospital. It meets the needs of patients, they're happy with the services, patient will be higher, and we can achieve our goal of reducing the prevalence of cervical cancer. M1 is commendable, they've taken the initiative, and I'm happy the president has said that M1 is a continuum, and she expects the incoming executive to continue along with our long-standing tradition of combating cervical cancer. We can now have a collaboration between institutions and societies and stakeholders who can drive this process. So we are having a lot of resource persons from BOSOM, the Gynecological Oncology Center of Nigeria. We can also look at SOGOM, we can look at NMA, other allied healthcare workers. We can create a collaboration that is formalized and have rules and responsibilities for those who can operate at the primary level of healthcare, at the secondary level of healthcare, at the tertiary level of healthcare. Beyond that collaboration at the platform, it may not necessarily exist within direct government supervision. It could be an independent coalition that will attract funding and international donor support ultimately, if we can get our structure right. And then we need to have a mechanism for data management and client flow. It doesn't necessarily have to be a big infrastructure. If we remember the COVID-19 vaccination process, people had to just open your phone or your tablet, and it's a cloud-based system that has bank-level security that are widely available. Every center that registers either through M1, through BOSOM, or through SOGO or NMA that want to be part of the national framework for private sector cervical cancer screening is given an identifier, and your facility is registered on that database. And when you refer a person to somebody else, the person is expecting that client and can call. These technologies are available, it is possible, and it makes our follow-up and referral mechanism very easy, and it does not require expensive infrastructure. You can access that platform with your mobile devices that you use for regular phone calls or your tablets. And then within this framework platform, we expect every facility to be known and to have linkages, and they can communicate. So it is kind of a smart platform where we know patients are coming up and probably have a mechanism to call those patients. You were referred to us last week and we didn't see what seems to be the problem. This kind of little interventions can make that big difference. And if we do it right and we have our data right and we can show that in the first 1 year we saw 300, 400,000 or 1 million Nigerians, government will listen, WHO will listen. The world is moving towards control and eradication of cervical cancer with the 90-70-90 program. We can scale it up and within a short time, we can actually see that the professional associations have provided leadership using appropriate technology and structure to ensure that we can manage cervical cancer. Because what we've been doing in the past few years have been opportunistic screening and see and treat, but without a very, very efficient or reliable data management process. Or I've had people call and say, we saw some persons in the rural community, we saw one looked at invasive cancer, we refer the woman to you, did she come? And she never comes. Nobody knows what happened to that woman. So if we can think beyond this and see what's the next step, and part of the resolution from this seminar we had is to have that collaboration and the vision to push it forward. I think the impact will be quite maximal, and we'll actually begin to see sustained and visible drop in cervical cancer prevalence in Nigeria. So at this point, I'll say thank you and I'll welcome questions. I'll just share that in the national policy document, there's a referral form that has already been developed in hard copy. Questions can download them online and then you can print them. But that form too can also form what can be put on the virtual cloud-based system that you can access for your phone and fill for any client and when you need to refer. If you have a network of cluster of everybody around Abuja, we use this national hospital, then you can have that network for say middle belt cancer screening network, and the hospitals around the tertiary care facilities are linked up, and so we can have that connection. I think we can take it up to the next level. Thank you very much.
Thank you so much, Dr. Michael, for your very inspiring presentation. Before we take questions, I just want to respond to some of your suggestions about collaboration. I want to say that there are many things we do as professionals that sound very funny, and if sometimes you consider them outright weird. Before COVID, we spent huge sums of money from January till December, traveling from one part of the country, attending a lot of events, attending a lot of conferences, and some of us even go out of the country to attend. But by the grace of God, we found a way around that just because of COVID. This particular program we are having with a reach of over 200 today. Yesterday it was over 350. The first day it was over 400. If it was before COVID, we would have spent not less than 5 million to reach these people. So since last year, I have been advocating to professional associations, particularly professional medical associations, that the money we have saved from traveling by doing things virtually, let us shift that money to implement plans and actions that we've been talking about sometimes for 10 years. So we've been talking. We say government should do this, government should do that. I just want you to know that it's not everybody in government that is an expert. And the experts in government are so few to be able to make the change. So we as professionals need to rise up. Now your call for collaboration is overtaken by events, sir, because we are collaborating. How did I get to have the contacts of GOSON members? It was from a comment from one of our doctors, Dr. Aisha Mustafa, when she said that, she corrected me that we should promote this visual inspection of acetic acid and the treatment, that it is for pre-malignant lesions, because I had used the terminology early cancer treatment or early treatment of cancer, early detection and cancer. I said, no, it's pre-malignant. So I said, oh, fine. And I took that. And then when we now decided to go a step further from our mass screening, our target was 6,000. And we said, let us see if we can do some of these early treatments. And I had to go back to her because I felt she was the expert. Since she was the one that corrected me, I could have been irritated. Why is she correcting me? Is she not my junior? How dare she correct me? Am I not the national president? But every day I keep learning. And quickly, when I told her, how do we do this? Are there people who can facilitate this? Immediately, she gave me 6 names from the 6 geopolitical zones. And each and every one of them have been top-notch. I am so proud of you, and I want to thank you. So what I'm saying is that the kind of collaboration we've gotten from GOSON members, it's not even, it is, let's say, 5 times more than the collaboration we've gotten from people that we have signed MOUs. We've signed a lot of memoranda of understanding with several organizations, both government and non-government. But many of them have not even gotten us to the point where we can be organizing a joint program like this. So what I would like to say is that we should focus on moving with the coalition of the willing. That's the most important thing. Because even when you now do all the paperwork, all the write-up and all the formal things to say, yes, we are collaborating, people are just not ready to do much extra than their usual work. And the working as a medical doctor, as a clinician in Nigeria is so hard that after you have seen patients for the day or for your normal working hour, the next thing you should do is just go on holiday. Ideally, Nigerian doctors should not be volunteering for anything else because their jobs are so hard. But look at us, medical women, we finish our work today, we are here for 3 hours, and we go to the field, we go to churches, we go to schools, all over the place. We want to thank God for all those who have been volunteering. God is going to give you a double portion of blessing. However, I just want us to say that let us not be too officious about the way we collaborate. So the collaboration between GOSON and MWAN, it has started, Dr. Michael, and it will not end with this biennium in Jesus' name. Amen.
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 Any other comments, any other questions before we go to our last presentation?
Amen. I have comments.
Amen.
Dr. Etta Aripo and Dr. Shehu, you keep Medinat, you keep jumping in and out. Dr. Etta, you can unmute and give your comment or question.
I've been around, ma.
Okay, so, okay, let's have Dr. Medina. Yes, please.
Yes,
so that
Mama, just a contribution. Okay, just a contribution.
Hello?
Thank you very much, ma, for the wonderful conference. We are happy to have this kind of meeting, and we wish we'll have this kind of meeting in the future to come, by God's grace, hopefully. Our agenda is to target the secondary school age. So I don't know if the way I'm thinking, is it possible to involve the public schools in advocating for this vaccination and encouraging the girls taking? I don't know if there is any program like that. It's very nice.
Okay, let me just answer that quickly because you're breaking. The issue is we promote human papilloma virus vaccination. It is part of our campaign. We've done advocacy to the Federal Ministry of Health that in fact it should be made compulsory. However, because we have so many things on our agenda.
Thank you.
In fact, it appears that some people are even saying we have taken too much, we have beaten too much that we could chew. But I don't think so because the problems are so many and we as doctors are resilient. So as the problems come, we take them. Now, the issue is that we have been promoting right from day one of the biennium. We have a sub-theme, which is maternal neonatal tetanus elimination. And that is supposed to have been done through vaccination. Now, the TD vaccine 1 to 5, that's doses to make sure that all women of childbearing age are vaccinated and protected for life. It's free, it's available. You walk into the primary health center or any vaccination center and they give it to you so far as you're of that age range. So right from then, 15 years old, they are in secondary school, they should go. But how many are taking that one that is free? And that was one of our sub-themes. Now we have had cancer control even before this biennium, and every biennium, breast and cervical cancer must have a big, there must be a big focus on it. And we've done that judiciously in this biennium. However, the HPV vaccine is not free. 2 of my daughters have been vaccinated fully, and it costs 11,000 for 3 doses, Cervarix. Yes, so I had to pay 33,000. So what I'm trying to say now is that who is going to pay this 33,000 when the one that is not free, sorry, the one that is free, TD, tetanus toxoid, that one people are not taking. But now you are saying we should now get people to go and get the HPV. So it's for you to now say, is it that we have more cases of cervical cancer than tetanus, so we should take that? I would have suggested, why don't we deal with this one that is easier, that is already there, eliminate it, and then hopefully the resources for that can now be channeled. But it doesn't stop us. Anybody who is ready to pay that 33,000 per woman of childbearing age, please bring. If you bring the money, we'll do it. But as it is now, it's difficult for us to say as an association, we're going to support it. Where are we going to get that kind of fund? If anybody gives us the fund, we're ready to do it. Then the other issue is, how many people are ready to volunteer? When we talked about the planning, we had a planning meeting for this program. The practical session, we were getting responses from the states that they are already overburdened and they will not even be able to host the way we wanted to do the practical session. So the question now is, if we don't get cooperation from the host states, we have to forget about the practical session and hope it can be done in the next biennium. So we are hoping that people will be willing to volunteer. The question now is, how many people are ready to go out? Some people say it's the same people again and again and again that keep coming out, and they're already tired. All through last year, this year, they have been volunteering. How can that happen? That means we have some members who are on the WhatsApp group and all they do is to post pictures, whereas people are dying and they are not volunteering to help reduce the deaths. So the question is, the leaders of the various states have to go back and sensitize. When you say M1 should take this up, it's not me, or it's you. You are the M1. M1. So when next your state president is calling you and you now give all your excuses, know that you have failed. So that's what I want to say concerning taking up HPV as a campaign. We're ready to do it, but it's not a one-man show. It's not a one-woman show. It's not a one-leader show. It is something that all of us must commit to. I hope I've answered your question. All right. So
yes,
Dr. Etta.
Thank you.
Yeah, thank you, ma'am. My question is directed to the last presenter on the referral system. In 2015, in our clinic, we saw a 45-year-old woman. On examination, she had this classical fungating friable cervical mass. And of course, it was spot diagnosis for cancer of the cervix. We referred her to LUTH. When she was seen at LUTH, their radiotherapy machine was not working. So she was referred to UBTH. And she had one session there, but because of the proximity, she was referred from UBTH to Ife. This since is closer to Lagos. And after she completed her chemo there, it wasn't okay. So she came back and we had to refer her to Kelbu Teaching Hospital in Ghana for cryotherapy. And after she did her cryotherapy for 3 months in Ghana, she came back and the outcome was poor as she lost so much weight. And we sent her back to LUTH for palliative care and for further care, but she refused. She declined going to LUTH. So we had to keep her on palliative and gave her so many injections. And of course, it was the end of life care for her. So, but if we had this referral system from the beginning, we would have known which machines are working or where she can go get cryotherapy, would have just sent her to Ghana straight away. So I think this presentation is very important. The the system should be drawn so that across the country we should know which facilities have these machines or where we could send patients straight on for proper and immediate care. Thank you. And of course, she had 2 children. She had a teenage daughter, which we advised to go for the vaccination. Thank you so much.
All right, thank you, Eta, for your comments. Am I supposed to respond or just for information purposes?
Please, sir, you need to respond because I am confused. Are they going to treat invasive cancer? The one that has typical, probably is the cauliflower type. Are they supposed to treat it with cryotherapy? I'm confused, sir. Please,
I think there must have been a mix-up. It must have been radiotherapy, not cryotherapy.
Oh, it must be radiotherapy.
Yeah,
Okay.
It's radiotherapy. They probably went to at Kolebo in Ghana. So that's one of the things about when you work in silos, teaching hospitals not linked together, and secondary care facilities not knowing which facilities are available where. I think one of the biggest problems in healthcare in Nigeria is that we're not functioning as an efficient system. Healthcare is supposed to be a system. When the patient comes in contact with the healthcare system, whether at a private level of healthcare or at the public sector, the patient is moved, that is managed appropriately there, or the patient is moved on to the right place that has bed space, that has facilities, that has manpower. But even for doctors, you don't even know what's available in the next hospital. And you can find somebody with, like this patient, very unfortunate case, with cervical cancer, goes to Lagos, no equipment, comes back, goes to UPH, goes to Ife, ends up in Ghana. We've lost like 6 months and the cancer has even progressed to incredible stages. Look at the woman who's bleeding in labor. You go to the one hospital, teaching hospital, no bed space, hospital B, no blood, hospital C, no ambulance, until you finally get. So we're not working as a system. If we had a functioning system that was linked and technologies are available, patients leaving one point of healthcare, as the other system is already alert and knows that they are coming. So the woman who has pre-malignant lesions and has no complaints, just evidence of HPV infection. If you refer her somewhere and she goes there and they say the person is not available or the equipment is bad, she will disappear back into the community. So we need to be sure that we, as much as possible, the healthcare facilities offering these services are networked in some way, and they also are linked to upper level and lower level healthcare facilities so that the stress on the patients, remember, many of them have no complaints, just abnormal screening tests. So that the stress on them is minimal. Taking them away from their work, they end their daily livelihood to seek treatment for something that's not disturbing them. There's a lot of sacrifice. So if the system is not efficient and meeting their needs, we may lose them. Thank you.
Dr. Rekia, your question.
Thank you, Ma. I just wanted to say that I think he didn't mean cryotherapy. I think he meant brachytherapy. I think that's what he's talking about. Yes, he's talking about brachy.
Okay, thank you very much. So I just want to add that when we talk about having an efficient system, the efficient system is you and I. It's not the Commissioner for Health or the Permanent Secretary or the Governor. It's you and I. And so whenever we find a gap, let us think of how we will fill that gap. And I give you an example. Concerning violence against women and girls, we've done a lot in this biennium. We actually had harmful traditional practices and intimate partner violence as sub-themes. And of course, they all dovetail into violence against women and girls. And what happened now was that we wanted to create a database of where you can get resources. And the resources include where can you get physicians who are willing to take on the case for the treatment, do all that is necessary. For instance, the rape protocol, you may have a case of rape and you don't follow the protocol because you are too busy. But there are some physicians who are passionate about it. So you say, okay, send it to this physician. She's ready to sit down and ask all the very sad stories about details about how that happened. Then how do you get nurses too who can also be there? How do you get psychologists? How do you get legal advice, lawyers, and different things? And if you have organizations that have hotlines for referral, if you have organizations that can assist with shelters, we wanted to put that in a document state by state. And then we requested for information on that, and we didn't get any response. So we couldn't have that database. However, there is this sexual assault referral network that has a database of about 17 states where you can get information, at least starting point, so that people can get that support that is required, because there's so much support that is required when somebody is having experiencing violence against women and girls. Now, for this particular situation as to where you can get these facilities, because they, like you said, they break down here and there and all that. There is the Nigerian Cancer Society, and some of us in M1, we are members. And there was a time somebody asked, where can I get this? Where can I get that? And somebody puts a spreadsheet of where you can get different types of linear accelerators for the radiotherapy that is required. So that information needs to be circulated. I think I circulated it on the M1 major platforms, but it has to be circulated again and again and again in different platforms so that people should be able to get that information and don't have to suffer. Then the other issue is concerning the issue of the various teaching hospitals and what they have to offer. I do not believe that anybody will just get a referral letter from UBTH and just go to LUT just like that. Before you go, you have to make inquiries. Have a way to call, because it is so sad that you maybe arrange for an ambulance, carry somebody that is on life support, the person gets there only to get there and find out that the machine is broken down. The person will just give up out of hopelessness. So before you set on your journey, please, one very important component of referral is that you should call the place you're referring to make sure that those services are there, and physicians should assist. A lot of the times we just write the referral letter and we wash our hands off the patient. We should go the extra mile to say, oh, I'm referring you from Benin to Lagos. Let me just confirm from my colleague in Lagos that those services are there, so that the patients do not suffer of in a very inordinate manner. So those are some of my suggestions as to the kind of situation we have. And all these things don't require policymakers. It requires we who see patients every day to just be more, let's call it smarter or more efficient about the way we do things. And finally, there's the good old Google. So you can always Google and say, where is this available? And you'll see phone numbers and emails and so on, and you make your inquiries. So thank you very much. I think we have done justice to Dr. Michael. We want to thank you again, Dr. Michael Ezianuche, for picking up all the issues that will help us make our system more efficient and deliver to our patients quality care. Dr. Agbonle, I don't know whether you saw my message. I've asked you to make Dr. Anissa the co-host, and you still haven't made her. Please, if you can make her now so that she can come on and share her slides. And we have the last presentation for this 3-day training on treatment of pre-malignant cervical lesions.
Ma, please, you are now the host. I'm no longer host.
Okay. All right. Thank you. I've done that. All right, Dr. Anissa, you're very welcome. Thank you. Please, can you give us your final presentation, which is on infection prevention and sterilization.
Can you hear me?
Very well.
Okay. Good evening, Madam National President, our distinguished speakers, and all members of this House. I will be taking the last lecture, which is on infection prevention and sterilization in cervical cancer screening services. I will follow this outline. Screening and treatment of pre-malignant lesions of the cervix can be a source of transmission of infection. And this is more so in our environment, where our screening services are usually opportunistic screening. So in most cases, you have outreaches that you conduct in order to treat. So in most cases, you have a lot of women that you are screening in a day. So, and that alone makes infection transmission very, very possible. Unlike in places where you have organized screening, a woman just walks in, maybe in a day you will do 3, 4, or 5 screening. You have a setup that is already set for screening. In those cases, the risk of transmission is usually lower than when you are conducting outreaches or when you are training health workers on how to conduct such screening, just like what we are going to do now. I've participated in this mass screening or training, and usually the issue of infection transmission is real. And if you don't take it very serious, you are likely going to transmit infection. And I think this borders on the issue of doing harm to your clients. So I think we need to take the issue of preventing infection during cervical cancer screening and treatment very important. And the healthcare practitioners can potentially spread infections among patients, and which is what is usually common. You screen this woman, you don't take the appropriate measures before the next woman comes, you are in a hurry, you have 1,000 women to screen and treat, you have 20 health personnel that you want to teach how to screen. So usually, and you have maybe just 1 day, 2 days, 3 days maximum. So usually there is a lot of stress, there is a lot of the patient load is usually very high, so the chances of transmitting infections are usually high. And another factor that may lead to this is, in some cases, you are not even using a standard clinical setting. For instance, if you go for outreaches in the villages, usually you just get a room, or if you are lucky to have a primary health care center that has facility, the setting in the room may not allow you to do what you need to do in order to prevent infection. You may have limitation of even where to keep your items. And again, you may have limited supply of items. You are trying to minimize the items. A typical case is when there is this plastic disposable speculum that you are supposed to use and discard. But in most cases, because you don't have enough, you will just decide to, let me reuse this one. After using, you may need to go back to high level disinfection and all that. And these are all the factors that lead to infection. So I can say that the way we do screen in outreaches, trying to train people, actually increases the risk of spreading infection among our patients. And also, infections can spread from health workers to clients. The health worker can actually be harboring an infection, and she can transmit it to client. And more recently, there is this concept of even the health worker getting infection from clients. But in most cases, it is the reverse. Usually the health worker can transmit it, but the client can also spread infection to the health worker. So what do we do to prevent infections? We have to take universal precaution whenever we are doing any procedure, and instrument processing is very important. The universal precaution usually protects infection from health worker to the client, or from the client to the health worker, while the instrument processing and work environment cleaning prevents the infection from one client to the other. So how do you prevent infection among clients? This issue of universal hand washing hand with soap or alcohol-based hand sanitizer. In fact, we just finished training some health workers in Kaduna State. In most cases, as I've said, because of the number of clients waiting and all that, in most cases, we use the alcohol-based hand sanitizers. And if you consider the volume that you are supposed to use of the hand sanitizer you are going to use and the duration it takes to prevent those infections, you know most of them are not even doing it. So in most times, you have to be reminding them, have you washed your hand? You may not have running water. We have centers that don't even have running water. So even getting the water to clean your hand with soap is a challenge, but we can't, we just have to look for a way to do it. Then wearing gloves when touching broken skin, mucous membranes, blood, and other fluid-soiled instruments and all that. Wearing the gloves is usually not the problem, but it's what we do the gloves. You will see a person that is doing screening for women, she wears her gloves, finishes the screening, then uses that same glove to use pen and to fill forms. This is very common. Or you use the gloves are almost finished, you said, after all, I didn't even touch the patient. Maybe I will just use the same set of glove for the next patient. And most of these things are due to lack of resources. So we wear gloves, but do we do the right thing while wearing gloves? If you finish wearing the gloves, you are supposed ideally to decontaminate even before removing. But in most cases, you see health workers using the gloved hand to pick other items, to touch other items, to use biro, to fill forms and all that. Then processing of instruments. Ideally, these instruments, will come to that later. They should be sterilized or at most high-level disinfection. But how many centers can ideally process instrument, can have facilities for sterilization? In most cases, it's the high-level disinfection. And do we have the adequate the chemicals that we need to use for the high-level disinfection in adequate amounts? This is another question we need to ask ourselves. Then disposal of waste as per standard guidelines. I'm sure most of us have passed through hospital verandas or even during outreaches, and you'll just see an open dustbin with all sorts of instruments. Then safe work practices. In most cases, you may see a room that barely carries the hot. You have to shift before the patient passes. So where do we even keep our instruments? They ensure environmental cleanliness. This is also all part of the universal precautions we need to take. That then preventing spread of infection from health worker to clients. Apart from imbibing all other things, hand washing between clients. If you see this client, ideally you are supposed to wash your hands before you see the next client, but that may not be possible, as I've said. Wearing double gloves. Sometimes we have even the single gloves, you use it for many patients because we lack them. Then using physical barriers such as aprons and face masks. Then avoiding needle stick injuries. During the visual inspection with acetic acid and Lugos iodine, during the painting of the cervix, some prefer using needles, but in as much as possible, it is better to avoid using sticks because they increase the risk of getting infections. So it's better to use a spray or use the needle without the syringe. Then using only sterile instruments. So how do we process the screening services? And all instruments that should be used should be decontaminated first. Then after decontamination, they should be cleaned. And after cleaning, they should be sterilized. This is very important. But as I'm telling you from the experiences I've had, ensuring that these processes are done can be a very, very big challenge, especially the sterilization and the decontamination. So what do we mean by decontamination? And decontamination is the first step for instrument processing, and it means immediately after you finish using your instrument, especially the speculum and other metallic instruments, you should soak them in 0.5% chlorine solution for 10 minutes to ensure that soiled surgical instruments and other items are safe for further handling by trained health workers. Because if you don't do that, the health worker that is to clean the instrument is also put at risk of getting the infection. And in most cases, if the chlorine we have is not the 5%, the household chlorine is about 5%. So, but we'll come to that. This step promptly and efficiently inactivate viruses such as HIV, hepatitis B, and hepatitis C. So that is what it does immediately you finish, because those instruments that you use on patients are in direct contact with body fluids. We know the genital system, direct contact with the vaginal wall and the cervix and the mucosa. So immediately you use them. Please don't place them anywhere. As you are moving them from the patient, put them directly in that 0.5% and let them stay there for at least 10 minutes. I know sometimes if you are in a hurry, you may just rinse them in the chlorine water and then wash them. Clients are waiting, but I think we need to take the infection prevention very serious, so that a woman doesn't come for screening, she doesn't have symptoms, she doesn't have anything, and then she's going back with infection. Then the work surfaces such as trolleys, couches, tables should also be wiped with 0.5% chlorine or 90% ethyl alcohol in between clients. Immediately, I know some use something like a Macintosh, but everything should be cleaned. Once a patient, even if there is no stain, you should clean. We know we are dealing with microorganisms. So if you don't have the 0.5% chlorine solution, it can be made from household bleach, which is usually in most cases about 5%, and this is the formula. The total parts of water you are going to use to dilute the household bleach can be calculated. If, for instance, you have a 5% household bleach and you want to make it to 0.5, all you need to do is divide 5 by 0.5, which gives you 10, then minus 1. So you'll put 1% of the household bleach and then put 9 parts of the water, and this makes it the 0.5% chlorine that you will clean the surfaces for, all the working surfaces. Then you soak the instrument that you use for that particular patient for 10 minutes before it goes to the next level of processing. So after that, after it has stayed in the chlorine water for 10 minutes, then the instruments are removed and then scrubbed. There are brushes that you are supposed to use to scrub your instruments. I've been to centers where after that chlorine bleach, all they do next is just to remove it and then rinse it without scrubbing it. But ideally, you are supposed to use a brush and detergent to clean, to wash all those instruments, to make sure that other body fluids, blood, tissue, and debris, and all other microorganisms are removed from that. Especially blood, once it dries or you have a lot of bleeding or the body fluids, they tend to stick to the instrument. So after that, that is not all. You need to clean it with brush and detergent. And the health personnel that is doing it needs to wear protective gloves. And you should know that after the washing, you should rinse them with water, because if you are using chemical high-level disinfection, the detergent may, if there is any residue of the detergent on the items, it will interfere with your chemical disinfection, which makes it suboptimal. So after brushing it, ideally you should rinse it very well under running water. And the staff that are doing this should wear utility gloves and also protect their eyes from splashes while cleaning. So after that, the next step is the sterilization, which is the final step for your instrument. And sterilization eliminates all microorganisms, including endospore. And that is why it is the highest and the most preferred method of instrument processing. So it should be performed on any item or instrument that comes in contact with the bloodstream or tissue under the skin. For cervical cancer screening services, the instrument that usually has the largest contact is your speculum, which you insert inside the vagina. Then in some cases, you use forceps. For instance, if there are secretions on the cervix that you need to clean, you can use forceps. Sometimes we use broomstick, as Prof. Ugu has mentioned before. So any instrument that you have used on the patient should be sterilized. And ideally, sterilization is the most recommended procedure. However, when you don't have sterilization, you can do high-level disinfection, which I will highlight later. Then the sterilization, you can do steam sterilization, which is the autoclaving, dry heat, and chemicals. What we usually have available is either the autoclaving or the chemicals. And the chemicals are the ones that are readily available in most cases. Autoclaving, not many centers have facilities for autoclaving, and it takes time, unlike and it has more protocols involved more. So the chemicals sterilization is usually what we do in most cases. So for the autoclave, high pressure saturated steam sterilization is the ideal, and the wrapped instruments remain sterile for a month unless they are open. And usually in centers that have you can sterilize your instruments, they will write the date that it was sterilized and the date that it will expire. But the main challenge for us doing screening, especially this type of screening, is the sterilization. Usually you do many instruments in one pack. So sometimes you open the pack, you leave it open. Sometimes you use unsterilized instruments to pick instruments from that sterile pack, which contaminates the pack. Or sometimes they may even expire before you use them. So there are a lot of challenges, except if you want to pack each item separately for each client. This is another way of preventing infection. For each pack, you just have instruments for just one client, so that once you finish, you know you have finished using that instrument for that day. But this is very costly, and in most cases, the resources are not available. We are just trying to see how we can screen with the little we have. Then the other form of sterilization is chemical sterilization. You can soak it in 2% glutaraldehyde for about 8 hours, or in 8% formaldehyde for 24 hours. And these ones usually come in commercial packs, but they are usually very expensive, but they are usually more readily available than the autoclaving, because autoclaving, you need a machine to autoclave. Then if you use chemical sterilization, it should be rinsed in order to remove the residue of the chemical, so that you won't cause any harm to the patient. Then high-level disinfection. If sterilization is not available, then the only other alternative is high-level disinfection. And it involves boiling in plain water after you have decontaminated, you have cleaned. That is, you are just waiting for the last process of sterilization, but you can't do sterilization. Either you don't have the chemicals and you don't have autoclave machine, then high-level disinfection is acceptable. You boil in plain tap water in a clean vessel for at least 20 minutes after boiling has started. So you start timing after the water has started boiling, your instruments have started boiling. Then after that, you soak your instruments for about 20 to 30 minutes. And I don't know from other centers, but where I practice and the environment around me where we have been doing this screening and training health personnel, in most cases is the high-level disinfection that we do. You soak in chlorine solution or hydrogen peroxide or glutaraldehyde. So in most cases, this is what we do. And even this one, most health workers hardly do it, because in most cases, doctors were not directly involved in processing these instruments. It is usually the nurses and the health assistant that do it. All at the end of the day, when you come to do your procedure, you will be given items to do it, and you assume. But I assure you, when I went for inspection to see really how they are doing these things, I was surprised to see how they are being done. So this table somehow summarizes what we need to do. For speculum, forceps, which is usually what we do, you decontaminate, you clean, followed by sterilization or high-level disinfection. Then if you have autoclave, good and fine, you can sterilize. If not, you go for the high-level disinfection. For gloves, ideally, we are to decontaminate. If you finish using your gloves, you are not just supposed to remove them. Even the removing the gloves, there is a way you are supposed to do it, so that the dirty part, the part that you use on your patient, doesn't come in contact with your skin, so that you remove one glove inside the other glove and then dispose it in clearly labeled waste container. Then for the thermal ablation device, we decontaminate and then we wipe. For the thermal ablation device, we don't autoclave, we don't put it for high-level disinfection. All we do is we decontaminate and then wipe with ethyl alcohol or methylated spirit. So in conclusion, cervical cancer screening services is a potential source of infection to both the practitioner and the client, especially where you have limited resources and where you are doing mass screening or training programs where you have a very high patient load. Then the potential for transmitting infection especially between clients, is very high. So we should make all efforts possible to maintain high level of infection prevention measures. Thank you all for listening.
Very, very much. I am so relieved. I'm so relieved that I can be here till the end because of what happened yesterday. Actually, 2 of my 4 devices have gone off.
So I'm operating with 2 and 1 is still fluctuating. So we thank God we've made it. We've had all our 10 presentations. Those of you who have been with us from the beginning, you've got your 10 CME points. Please ensure that you send to the relevant email. We are using 3 different emails just to make sure that people don't just come and get 10 points when they did not participate. So we are now ready for questions and any other, not only questions concerning Dr. Anisa's presentations, but questions from other presentations, for other presenters, even if they are not here, we'll find a way to get the questions to them. And then questions concerning the practical sessions, because we are going to hold the practical sessions in 6 geopolitical zones. That's the plan. We do not know if we'll be able to achieve it. But even if we can't do all 6, at least we'll do as many as possible. So we have them in Kaduna, we have in Gombe, we have in Plateau, that's Jos, and then we have in Benin, we have in Abakaliki, and we also have in Ile-Ife, hopefully. So M1 is, National Secretariat is ready to sponsor at 1 person from each state, including the hosting state, to get there and attend the training. Now, we also felt that since during the planning meeting, we talked about having 10 people for the practical session, maximum of 10 people, that we could also get some of our male doctors to also participate. But we are not going to pay for their transport. So it's either they are actually in the same location as the host or they find their way to those places. But we are not charging them anything. They can come and join the medical women and participate in the practical. So if you have any questions for Dr. Anisa on infection prevention and control, or for the next step, which is the practical, please, this is the time. Thank you very much. We have Dr. Isikak, Dr. Isikak's hand is up. Dr. Isikak, you can unmute and ask your question.
Yes, ma. Good evening, ma, and I thank you for this program. My concern is how we are getting the material. Where are we sending the email to if we are to get the material for the lectures that we have had so far?
We're going to send you your materials according to the CME. So first day, as you get your CME we're not sending all the 10 CMEs once. So the first day you get 4 CMEs, you get your 4 presentations. The second day you get 3 CMEs, you get the 3 presentations. The third day, which is today, 3 CME points, you get 3 presentations. So as you send us the message to the various emails that we are putting, that's how you're going to get the presentations and the CME points. They're all free.
But what I'm asking is some of us that did not know we were to send the email, like in this first lecture or second lecture that we didn't send email. Are we not going to receive the material? I'm particular about the material, not the CME points.
Okay, all right. The question I want to ask, if you have been here from the first day, were you not seeing it in the chat? We sent up to 5 times in the chat, sent to this email. You're supposed to copy that email and keep, and then later on you now send your details. What I'm asking, did you see the email?
Okay.
It's the same email, yes.
Most of us
okay, it means
as we are sending you the CME points, we are also sending the same email we are using to send the CME points that we are going to use to send the materials.
Okay, ma. Thank you.
Any other, Dr. Chioma?
Yes, ma. Please, ma, I want to know, are we getting email as regards to the practical? Because, like, I will be...
The practical, which state are you from?
Anambra.
So, if you're interested, Anambra has not sent a nominee yet. So, you tell your Anambra president that you're interested. He should send you. When you're supposed to send your
your name, institution, and your phone number. And then once we have that, we'll send all the information as to the practical. MWAN is going to sponsor transportation, accommodation, and feeding to go for that practical and come back the next day. You're only spending one night.
Okay. When is it likely to be, as in the month?
Yes, we are hoping that by the end of August we would have concluded. So some states like Edo State, they have started presenting, they picked their states, but not all states. So we are hoping that very soon all states will tell us the days that they have chosen for the practical. The practicals are where the facilitators they are residing, so that all we need to do is to get the participants to the facilitators, and we don't need to start carrying the facilitators out of their location of residence or work. So the location is Kaduna for Dr. Anissa, Gombe for Dr. Farouk, Plateau for Professor Musa, Benin for Dr. Michael Ezianiche, and then Ife for Professor Kayode, and Abakaliki for Professor Abu. Can we have Dr. Isam? Your question.
You can consult me, you can ask me what to do, and also we can plan together. But you have taken the steps and the submission without.
Dr. Nsang, can we have your
question? Mine is for the trainers, apart from the sponsorship fund that is also interested to. Hello?
I'm hearing you. Go ahead.
Hello?
We are
okay,
hearing
good
you.
evening,
Go
everyone.
ahead. Yes.
Okay, mine is a question concerning the training, the practical section. I want to ask, apart from the sponsorship from MWAN, can it be self-sponsored, like anyone that is interested to also take part in the training? Can the person sponsor his?
Yes, you can send an email. Send an email to Dr. Okwek, that's the National Assistant Secretary, to say you want to sponsor yourself, and you take it up from there. Thank you.
Thank you, ma.
Dr. Christiana.
Yes, ma. Thank you very much, ma, for the wonderful program. Please, my concern is still about the CME point and the materials. Actually, I've been attending from the first day, but the chats in the chat box were so many, and there were so many email addresses, and I didn't know which one.
Ask any of your colleagues. Ask any of your colleagues. Ask any of your colleagues.
It's okay. Thank you.
Dr. Ojule.
Good evening, everyone. Yes, I'm on. Good evening. Madam President, congratulations. Well done so much, ma.
Thank you.
All right. I'm a bit concerned because I think I actually think that everyone should think about not just the therapeutic and the diagnostic part of this program. We are Africans. Many women don't find it easy to just bear all to even fellow women. So I think part of this program, we should talk about considerations on the part of the patient, like how to protect, cover, all those kind of things. I sent a patient one day and she was just asked to put all and come and lie down. That she didn't find it funny at all. So let's teach people also to be considerate. Don't just tell somebody pull everything and go and lie down. We should be able to protect our fellow women, maybe have some drips around their perineum and all that, instead of just leave them to just lie like that, even though they are women like us most of the time. But I've also seen men doing this
the procedure. So please, I think everyone can champion this. Thank you so much.
Thank you for that reminder. We've noted it. Dr. Ola, the name is no longer there. Okay. Dr. Rekia.
Hello. Actually, for me, I just want to congratulate M1 and congratulate the organizers and the president for the very high quality lectures that that we saw. I joined from the first day, and I enjoyed that. I made sure that every day I find time to make sure that I join, because the lectures were very high quality. And it's also extremely impressive to see the hunger for knowledge amongst our doctors. The first day there were over 400 people, and the number consistently has not fallen below half of that. So I want to congratulate you, and I think we need more of this, because if you see the questions that come, high quality questions actually, and high quality lectures, I think we need to do a bit more as time and resources permit, and so that more people get to understand this thing, and we help to resolve some of this problem for a cancer that is totally curable and actually totally preventable. And it's cancer that is almost not existing in some other countries, but it's a main issue in our countries. So thank you very much and well done. And it's very nice, and I'm proud to be an M1, and congratulations and well done.
Thank you, Dr. Rekia, for your kind words. It's for all of us. My greatest joy would be to see other professional associations replicating things like this. We have quite a number of affiliate bodies to NMA. It's not only M1. And I will just hope that if all of us wake up and do things like this, be passionate in spite of the challenges persist, I am sure we'll be able to change the health system in the next 5 years. So thank you for your kind words. Dr. Elizabeth Ejiga.
Hello, can you hear me? Hello? Hello?
Yes, we can hear you, ma. Please talk.
Okay,
We can
so
hear you.
Okay, thank you so much. I said I was thanking Madam President and her crew for putting this together. It's been very informative, and I want to encourage that you pass on this as you round up towards the next election. And I wish the incoming ones greater grace to keep us abreast of what we need to do. Well, my question is about personal sponsorship to the practical section. If it will be made available to the different states, I mean the locations, considering the fact that some of us that are in the private sectors will want to be there for the sake of the teeming population that come to us too for care. So we'll appreciate if this is made available so that we'll have opportunity to be represented. Thank you. Hello? Okay. I hope it's taken.
the central bank now issuing a statement asking the bank to ensure a hedge-free of the new retail FX sales. The regulator in one period letter to all the
no, I didn't.
no holding of FX delays of that version of FX so FX window that's now been moved in terms of supply of FX by the center to deposit money. That's the new horizon. So the center bank to be ensured that everything goes no diversion, no denying one to give you, come back tomorrow. Every customer must be having satisfied order. That's it. So to settle and be to update clients on the status. In other words, if you go there and the bank says, well, you know what, they are true to basic, then there should be a system to allow you a request that's been fulfilled, then you can go keeping the customers sit down. The bank executives who say they're for the new this meeting listening to.
Good evening, everyone. Sorry about that. I was I think the national president is also out, but I'm seeing some hands raised. I'm seeing hands raised. Viola Mohammed. Please,
thank you very much. Thank you very much. Good evening. I want to add my voice to congratulating the national president and her team for this very insightful and excellent presentation. My question is, where is the place for advocacy? Because some of us are too old to get into the field and may not even be qualified to do so. But how can we get involved? Because I believe advocacy is so important.
Dr. Yahaya, any response?
Okay, ma. I think the role of advocacy cannot be overemphasized. Even if we can't go to the field, I think there are many things that can be done. Number one is if we can get a political commitment to this. As somebody raised an issue of HPV vaccination, if we can have some people that can advocate the issue of HPV vaccination so that girls can get this vaccination free and compulsory, that will be a major step. And apart from that, even the screening, as we are speaking today, we don't have a robust national program for screening for cervical cancer. All we are doing in most cases is opportunistic screening and then organizing outreaches here and there. So I think the advocacy aspect is the most important one we want, so that we'll have some sort of political commitment to have all levels of prevention of cervical cancer available at Nigeria. We should vaccinate our girls, and this screening should be made available everywhere so that a woman just walks in, gets screened without paying a kobo, and gets treated without paying a kobo. So I think the advocacy cannot be overemphasized, which I think everybody can do, whether you can go to the field or not. I think that is where we should come in, especially those that have connections. The experienced ones, the ones that have connections, can do the advocacy very well. As Madam National President has said, for the vaccine, where if we get people that are willing to sponsor, why not? We will do it. Thank you.
There are two hands raised, so I want to just take the questions. Dr. Viola Mohammed, please unmute and ask, and let's see how we can answer.
Oh, I asked the question about advocacy. I forgot to put my hand down. Sorry about that.
Then Mbanusi Claire. Please unmute yourself and ask. Then we have Halima Farouk, so that I think we should close for the day.
Hello, good evening.
Evening.
It's more like a request. I don't know if you have a WhatsApp group or Telegram platform for M1. If we do, is there any way we can get the link so that we can join and know what's happening from time to time?
We do. Which state are you in?
From Anambra State.
Anambra. Please get in contact with Dr. Ajato. Dr. Ajato. Where do you work?
Okay, I'm currently at Bayelsa serving, but then I hope to go back to Anambra after my youth service. So that place is my main base.
Okay. Dr. Mbanusi, what you do, please send me a text. How do I get in contact with you now? So that we can just get this to your email. Yes, to my email. Please send the first email there. Just send it there. Any of them, send it there, and let's see how we can just get information to you.
Oh,
we
okay.
have so many groups. We have so many. So we'll get that for you. That will be easy. Okay.
All right. Thank you.
Dr. Halima Farouk and Dr. Julie, please, after those two, I think we should end. We've done so much.
Okay. Thank you very much for this wonderful movement. I just have a bit of a clarification. I need a clarification from Dr. Anissa Yahya. It's about using the thermal ablator that we commonly use. I don't know your experience now. Please, you know, there are, based on manufacturers' recommendations, there are those that have, you know, that you have to use a particular solution to do your decontamination or sterilization. That's what the thermal ablator probe. But how about those that advocate that probably the use of the ablator itself is self-sterilizing? I don't know. What's your experience on that? Do you think we should continue using it as self-sterilizing, or we still need to put some additional solutions to sterilize before we treat the next patient? Because most of the times it's only a single or highest maybe 2 or 3 probes, and then you have to do a massive screening. So how do you go about that with the sterilization?
We clean in between patients. You don't need to do all the processes, but we use alcohol in between, because most of the instructions they will tell you just wipe, as I've mentioned, except if you are seeing something an obvious stain on it which you hardly see, but you still yes, we wipe them off with chlorine water, or if you have methylated spirit, that is, in most cases we use spirit. Yeah. In fact, there is a center that they bought this what do you call it? These wipes, sterilizing wipes.
Okay.
Yeah. Once you finish, you just clean it with the wipe, and then thank God if you do the massive screening, not everybody. You don't need to use it on everybody. Just the few that. Yeah. So.
So thank you very much, because I realize that most of the solutions are not even friendly to the thermal ablator. Yeah, so all right.
Yeah.
All right, thank you very much.
So lastly, Julie Yemi Jonathan, sorry.
All right. Hi, everyone. Good evening. So I want to especially thank, I think I dropped something on the chat, but I just thought I reiterate the fact that CHAI, in partnership or in collaboration with the Federal Ministry of Health, have already begun something. They've already begun, like they took up the task towards the elimination of cervical cancer based on the WHO declaration. And we have over 177 public, primary, secondary, and tertiary facilities across 3 states that are currently providing cervical cancer screening and treatments using the thermal ablation devices. And I know that over 500 healthcare workers have been trained. So I think across these 3 states, Lagos, Kaduna, and Rivers, if you're within those states or you're in the neighboring states, you can reach out to any of the tertiary facilities or even the public sites, and you can get hands-on training and just mentoring or step down We have even come up with training manuals. So these are just things just to ensure that every healthcare worker can provide basic cervical cancer screening using VIA or VLI, and then can also do treatment. So I think it's important for us in Rivers. I'm available. You can reach out to me for us. I think I've been working a lot with M1, so it's not new.
Good.
So yeah, thank you very much.
Thank you so much. You're welcome. So I think on this note, my president, I don't know if she's, Ma, are you still there? Hello?
Yeah.
Okay, Ma, so you speak from here.
Hello?
We can hear you.
You said what?
We are closing. Any closing remarks, Ma?
Okay, I want to thank you all for participating. The job has just started. We'll find a way to get through with the practical and then so we are counting on everyone as partners in this fight to eliminate cervical cancer from Nigeria. Thank you and God bless you. Bye.
Bye. Okay, good night, everyone.
Bye. Happy.
Bye.
Good night, Nancy. Good night,
Bye,
Madam
everyone.
Thank you. Bye. God bless you.
Thank you. Bye.
Bye. Thank you, Madam
Bye.
National President Otagbole.
Practice
Bye.
what you are taught.
Thank you,
Oh.
Thank you, Madam President. We appreciate all the Thank you.
Practice what you have been taught.
Bye-bye, everyone.
Bye
Thank you
bye.
so much for
Bye-bye,
the different
everyone.
sessions,
Bye,
day 1 to
everyone.
day 3. God bless.
Bye, everyone. Thank you, Madam President.
Thank you,
Thank you,
everybody.
M1 National.
Thank
Winning.
you, M1.
Everyone for the wonderful presentations. Thank you.
Thank you so much.
Thank you, everyone. Thank you, Madam President.